So I will continue based on what Alex has already told you about myositis. So I'll dive first into a little bit about the classification and how do we really come to a diagnosis, mostly in research area, but we also apply these classification criteria in our clinical care as well. So first is Bohan and Peter classification criteria for polymyositis and dermatomyositis. This was established in 1975, and we still use this classification criteria as an educational tool in most cases, but also to understand the overall disease clinical features and pathogenesis. So first of all, the first bullet point on this is symmetric proximal muscle weakness. Almost all patients of myositis should have proximal more than distal, upper and lower extremity symmetric proximal muscle weakness. There are a few exceptions to that rule. For example, if you have a patient with clinically amyopathic dermatomyositis, or in some cases of antisynthetase syndrome, then that may not be the case. But mostly, almost all patients would have that proximal muscle weakness, which is objective. That means examiner can actually detect their weakness overall. It's way above and beyond just patient feeling generalized weak or fatigue. Second is muscle enzyme, and I think Alex spoke about elevation of muscle enzyme. And I always want to point out there are 5 different muscle enzyme: CK, aldolase, AST, ALT, and LDH. And I can tell you at least one patient a year I see after getting a liver biopsy because their AST and ALT, which are also liver function tests, were elevated, and they thought the problem is in liver, whereas the problem was actually in muscle. Third point is EMG, nerve conduction study, is very helpful. It helps us to differentiate diseases that are neurogenic, diseases that are neuromuscular junction, as well as myopathic. So the myopathic signal on EMG is very specific. We get short duration, low amplitude polyphasic units that help us to differentiate is the patient has muscle problem, nerve problem, or neuromuscular junction problem. Obviously, in myositis, we're talking about muscle problem. Then muscle biopsy is often helpful. We see myofiber degeneration, regeneration, mononuclear infiltrates, and perifascicular atrophy. And some of these features are general features that can be seen in any muscle disease, but some of them are highly specific, for example, perifascicular atrophy and so on. And then last but not the least, skin rashes of dermatomyositis are very helpful. These are 2 rashes that are almost pathognomic for dermatomyositis specifically. Now, obviously, these skin rashes do not apply to polymyositis, and these are Gottron papules or sign or heliotrope. So the way this classification criteria works is if you have 4 out of 4 including rash, then you have definite dermatomyositis. But if you have without rash, then it will be polymyositis. And you can have a probable criteria if you meet 3 of the 4 or 3 of the 5. Now, the problem with this classification criteria is it works great for dermatomyositis because of pathognomic rashes. But for polymyositis, where you don't have the advantage of skin rashes, you only have 4 bullet points, it can be misleading. And many myositis mimics can actually fulfill this criteria quite easily, and that's lead to somewhat overdiagnosis and misdiagnosis of polymyositis in our area. And another disadvantage of this classification criteria, as in any rheumatological criteria, if you see there are generally autoantibodies, and myositis also, and I will show in later slides, have many myositis autoantibodies. But in this criteria, there was no antibodies, mainly because the discovery of myositis antibody was after 1975. So what has happened in the field now is we've developed new classification criteria, which is called 2017 EULAR-ACR classification criteria, which you can see on your screen. The way this classification criteria works is you have various clinical features that you have to evaluate in your patient, and then give risk score based on that clinical feature if it's present. And there are 2 sets of clinic risk scores. One is if you have a muscle biopsy, another one if you don't have a muscle biopsy. And if you meet a certain threshold, then you have a definite classification for myositis. If you meet a lower threshold, you have probable classification for myositis. One thing I wanted to point out is the Jo1 antibody. You see it has the highest score of any clinical feature, and it's almost half of what you need to fulfill the classification for myositis in this classification criteria. And that tells you the power of autoantibodies. These myositis-specific autoantibodies are very powerful. In most cases, if you have the right antibody, then you probably have the disease. And then what happens in this classification criteria? Once you meet the classification, then you can divide them into various different subtypes, which could be polymyositis, if they're based on this classification tree, or dermatomyositis, or amyopathic dermatomyositis, or IBM. So based on the classification tree, we can actually divide it. So this classification criteria is currently being used in all clinical trials, but there are some shortcomings in this classification criteria that we are trying to overcome in next 1 or 2 years, which include, it does not include necrotizing myopathy, it does not include antisynthetase syndrome, it lacks other myositis-specific antibodies, it only has Jo-1, and it also lacks features from other skin rashes, ILD, and also lack MRI, as Alex nicely showed. It's very common nowadays to have MRI as an early test on myositis to see muscle inflammation, and this classification criteria also lacks that. So we are doing some work to improve this classification criteria. Next is I want to dive deep into the myositis autoantibodies. I've already given you some introduction about myositis autoantibodies. The way this Venn diagram is designed is they have 4 clinical subtypes: PM, dermatomyositis, overlap, or also called as CTD myositis, where you have a myositis and another connective tissue disease like lupus or scleroderma, and NM, which is necrotizing myopathy. Within these 4 clinical subtypes, you see other bubbles with different names on it, and each of these bubbles represent a myositis-specific antibody. And these myositis-specific antibodies represent a unique clinical phenotype that is within that antibody is highly, very tight, and can actually help in understanding the disease clinical phenotype, prognosis, outcomes, and so many things. And I will, in next subsequent slides, I will go through some of the examples to make you understand that within the clinical subtype, these autoantibody-based subtype can really help us to understand what would happen in my particular patient beyond just the overall myositis. Other important point I've already made is these autoantibodies are highly specific. For example, Jo-1 is highly specific, more than 95% specificity for having myositis. But each one of them are very poorly sensitive. That means even the most common antibody, which is Jo-1, has the highest frequency of around 5 to 40%. So if you just test one antibody, it's not good enough. You have to test the whole panel. And when you test the full panel of myositis antibody, the sensitivity increased from 60% to 75%, depends on which lab you're following. Now, first, what I will do in next several slides, go through some examples of these autoantibody-based subsets. These are called serological subsets. So first serological subset I want to talk about is antisynthetase syndrome, which is actually its own entity within myositis. So these are represented by a presence of antisynthetase antibody. What are antisynthetase antibodies? These are basically different antibodies which target amino-acyl tRNA synthetase. For example, Jo-1 target histidyl tRNA synthetase, and some of the other ones target a different tRNA synthetase. If you remember, tRNA synthetase are ubiquitous in all the cells. Their role is to do protein synthesis. What are the clinical features of antisynthetase? Now, I'm not showing myositis or skin rashes of dermatomyositis because those are commonly present, but some of the classic clinical features are in mechanic sand, which is shown on image 1 and 2, where the patient have roughening and thickening of the skin and cracking of the skin with almost sometimes bleeding, which seems like the patient is a mechanics, but in this case, turns out patient is not a mechanic and doesn't use their hand, and clearly there's inflammation leading to this. Next is polyarthritis. It can look like rheumatoid arthritis. I have misdiagnosed patients as rheumatoid arthritis, which later on then found out that this patient actually had Jo-1 antibody, and then turned out to be antisynthetase syndrome. Patients can have Raynaud's. Patients can have fever, and last but not the least is interstitial lung disease. In my clinic, one of the common referral patterns for antisynthetase syndrome is having double pneumonia, because these patients go to a community hospital with fever and that type of chest x-ray, and they get diagnosed as double pneumonia. But it turns out this was not a double pneumonia, it was interstitial lung disease. Overall clinical features, the triad of antisynthetase syndrome is ILD, most common feature is ILD, second most common in myositis, and then is arthritis. So we use this as a triad. The unfortunate part is that all 3 clinical features are not present in all the patients, and they're not definitely present at the beginning. So that's why even if you have one of these, you have to think that others could be present and then follow up the patients accordingly. Now, going from antisynthetase syndrome, I'm going to go take you to a world of necrotizing myopathy, which is also called as immune-mediated necrotizing myopathy, autoimmune necrotizing myopathy, or just necrotizing myopathy. And it comes in three flavors. One is the patient with anti-SRP antibody. Another one is the patient with HMGCR antibody. And last but not the least is many patients are antibody negative necrotizing myopathy. So first, SRP. These are the patients, they are the worst patient in terms of the disease. They have most severe and refractory muscle disease. These, unfortunately, are younger patients. They develop acute onset of muscle weakness with severe myalgias, very high CK. The reason their CK is so high because they are acutely necrotizing their muscle. Because they're losing so much of muscle mass so early, it leads to early atrophy. Because swallowing apparatus also is muscle, they can develop severe refractory dysphagia. But fortunately, they don't have non-muscle organs. They don't have interstitial lung disease or rashes and other problems. They have the poor prognosis and refractory to treatment. In fact, in my clinic, if our patient comes on a wheelchair after treatment, then it's generally speaking they probably have SRP antibody. I cannot almost all of my SRP patients. Almost all my patients who come in a wheelchair are SRP antibody, and that's why it's so important to recognize this subset early by doing autoantibody and treating them aggressively, because if you do that, then they tend to do better. If you look at their muscle biopsy, you see acutely necrotic fiber as shown in the figure, but very little or no inflammation. And also you see macrophages coming up and eating those necrotic fiber, cleaning it up, called myophagocytosis. If you go to another type of necrotizing myopathy, as you can see, it's exactly the same figure for muscle biopsy, because you cannot differentiate between immune-mediated statin myopathy or SRP antibody myopathy. At least on pathology, most pathologists cannot differentiate. There are some subtle differences though. But typically, immune-mediated statin myopathy starts during or after exposure to statin. Almost 80% of these cases have had some exposure to statin in the past. They develop weakness despite stopping the statin. This has a wide range of variation. It can be very mild disease to very severe disease, whereas SRP tends to be always more severe disease. They can have myalgia and arthralgia. Because it's a necrotizing myopathy, you see very high CK. And an antibody called HMGCR antibody is highly associated with this phenotype and can easily recognize this phenotype. Fortunately, these patients respond well to immune suppression, but they will relapse if you stop immune suppression early on. Next, I'm going to take you to some serological subtypes of dermatomyositis. So first, anti-MI2 antibody. This is somewhat, in most cases, one of the most common dermatomyositis antibody. It typically has milder and typical phenotype. It is only seen in dermatomyositis, not in polymyositis or IBM and others. It has a very good response to treatment, rarely develop any extramuscular features like ILD. They come with typical rashes, and generally speaking, they do well. Now, there is a subset of patients with Me2 antibody that are refractory. And that's because it's a large subset, so some of those patients are refractory. But generally speaking, they respond to treatment quite well. And then going to clinically amyopathic dermatomyositis, it's a subset of patients which have classic dermatomyositis rashes like Gottron papule or heliotrope, but they don't have any objective proximal muscle weakness. Now, if you do testing on them, they may have some subclinical findings of muscle involvement. For example, if you do an EMG or muscle biopsy, you may find some myopathic features or some muscle inflammation in few fibers. If you do muscle enzyme levels like CK, you may find mild elevation of CK levels. But objectively, when you examine them, they're not weak. So we call them as clinically amyopathic DM. We call them as amyopathic if they don't even have subclinical evidence of muscle involvement, and we call them hypomyopathic if they have subclinical evidence of dermatomyositis. But overall, it doesn't matter whether you're amyopathic or hypomyopathic, they behave the same, and that's why we put them together into this clinical clinically amyopathic dermatomyositis. Now, it's highly associated with this antibody called anti-MDA5 antibody. And this antibody is quite unique and important to know because almost different regions of the world have different frequency of ILD. In US, we found the frequency of ILD to be about 50%, 40 to 50%. But what makes the matter worse, that most of these ILDs are rapidly progressive ILD, which means from the onset of symptoms of dyspnea or cough to death or intubation or hospitalization or oxygen requirement is within 3 months. So they're very, very fast progressing, almost like COVID. There are a lot of similarities between COVID and anti-MDA5 antibody. And then they can also come with classic and severe rashes like cutaneous ulceration, vasculopathy. But the palmar papules that's seen on your slide are classic rashes that are associated with this antibody. So you can use the antibody or the rashes to diagnose these patients early. And if you diagnose them early and treat them aggressively, they tend to do better. But if you don't, then they actually have very poor survival. They have almost 30% mortality within first year, and in anti-MDA5 positive patients. So these patients are almost like a death sentence in 30% of patients if you don't recognize these patients early. Many of these patients I meet first time in the pulmonary ICU or when they are actually having severe respiratory failure. Now, in US and Western world, this problem is there, but it's less frequent because it's only about 5 to 10% of all my dermatomyositis patients have this antibody. But in Eastern countries such as China, Japan, this problem is very severe because 20 to 25% of all dermatomyositis have this antibody. So they have to deal with this quite a lot as compared to us. Last but not the least, I'm going to talk about this antibody called TIF1 antibody because it's highly associated with cancer. And it's a unique antibody which in one study at least shows a sensitivity and specificity of about 80 to 90%. That means if you have this antibody, then it's high likely that you are hiding cancer and that cancer is leading to the diagnosis of myositis or dermatomyositis. So when I find this antibody in my patients, specifically if they're elderly patients, I may tend to do a PET scan on these patients to find that hidden cancer.